Welcome and thank you for joining the Ortho Infectious Disease Educational Series, Understanding the Latest Approach for Perioperative Screening During the COVID-19 Pandemic, Benefits and Challenges of Dual Testing Today. I'm Mike Carboni. As you no doubt are aware, there are significant hurdles with testing patients for COVID-19, from the questioned accuracy of testing early in the pandemic to the availability of tests, not to mention the long incubation period, and that many are not aware that they are infected due to being asymptomatic. When it comes to pre-procedure screening, the challenges and consequences are heightened. To begin today's program, it's my pleasure to introduce our speaker, Dr. Karen Roush, MD, MBA, and Vice Chair of the Department of Pathology at Methodist Health System. Welcome, Dr. Roush, and thank you for joining us.
Hello, everyone. Thank you for joining me for a few moments today while I talk about our testing strategy that we utilized for Methodist Health System for perioperative risk and getting our patients back to the OR. We had two testing goals when we started this process. We wanted to protect our healthcare workers and we wanted to protect our patients. It's really the strategy that any healthcare industry or hospital would have. There are, of course, multiple layers to what protecting patients and protecting healthcare workers means. In this case, protecting healthcare workers from getting infected with COVID is paramount because if they're infected, they become patients to which we've done harm. And secondly, they are unavailable to take adequate care of incoming COVID patients. Healthcare workers have an obligation to protect our patients, first by making sure that we're providing adequate care for their underlying illness, whether or not that is COVID related, and second, to make sure that the treatment we provide for that illness is not causing more harm than the illness itself. So these are the goals that we had, and you probably have the same goals at your institution too. We would like to have a big, bright blue ribbon when it comes to the end of everything, showing that we've done the best that we could do with the scientific tools we had at hand. Basically, as you all know, there are two testing categories for SARS-CoV-2, and neither one of those are perfect. We have PCR and antigen testing, which is direct testing for the presence of viral material. The pros and cons of this sort of testing is, one, it can tell you who has the virus early on. Since viral genetic material or proteins fade around 4 weeks after symptom onset, it won't tell you who has been infected, and it won't tell you for a very long time in most people who is infected. And as you'll see and hear over and over in this presentation, the PCR and then the antigen test as well are up to 30% falsely negative. Serologic testing, or antibody testing as it's commonly referred to, is evidence of an adaptive immune response. It also has some pros and cons. It won't tell you who is infected early on because onset of antibody formation occurs 1 to 2 weeks after infection. Not all patients generate detectable antibodies, but the tests now have high accuracy and generally long-lasting in patients, months, as compared to PCR and antigen tests, which could be days or a week or so. So, like I've said, neither of these are perfect, as you will see when it comes to screening for COVID-19, but together they yield more information than either test alone. So we're going to spend a little bit of time talking about this schematic that was published in the Journal of American Medical Association, looking at several studies to come up with this graph that shows a timeline of infection and provides very valuable information in terms of testing results as compared to symptom onset and detectable COVID-19 infection. Up to 2 weeks prior to symptom onset is when the initial exposure occurred. Within 1 week from symptom onset, your nasopharyngeal viral load, as well as viable culturable virus, begins to increase. And by the time you're showing symptoms, both the viral load and viable viral cultures have hit their peak. Our ability to grow virus in culture tapers off fairly quickly, while detectable viral material hangs around quite a bit longer. While virus is still detectable by reverse transcriptase PCR, one can see that antibody levels begin to increase just after week 1 of symptoms. Of particular interest in this graph is the way in which both IgG and IgM have similar entry points in terms of time. For most other viruses that we study, IgM comes at first and IgG follows. IgM does appear to taper prior to IgG, but the full story on antibody longevity is yet to be told. The other thing to notice about this particular graph before we move on is that we are only talking about patients who actually develop symptoms. And we know from many studies at this point that up to 40% of patients may be asymptomatic or lightly symptomatic for the course of infection. Okay, so while we were being inundated with studies at the beginning of the pandemic, there were studies such as these indicating that operating on a patient with COVID-19 was found to increase mortality rates by 20%. I don't know about you, but we really wanted to avoid these types of outcomes. So literally, as soon as we started our PCR testing, we found out that PCR testing actually wasn't picking up all of the people who were infected. Well, how did we know if people were infected if the PCR testing wasn't picking it up? We found that out because we picked this up on subsequent tests, and that was important because it really showed that you couldn't reliably depend on a single test, and the reasons for that were bandied about by a number of people. I think initially many people thought that these tests were falsely negative because the collection procedures weren't very good. I am not one of those people who think that really, and I should take a moment to say here that my opinions are my own, and they may not necessarily reflect the opinions of Ortho Clinical Diagnostics or even Methodist Health System. So if there are opinions, I want you to know that they're my own, and so I'll take responsibility for those. I don't really think that the manner in which collection occurs is making a huge impact on whether or not these tests are false positive or false negative. Reason being is that there's a bit of data that shows there are essential equivalent results among a nasal swab versus a nasopharyngeal swab versus an oral pharyngeal swab versus sputum or even saliva. Now, some of these do have somewhat more sensitivity or likelihood of detection than others, but for the most part, these are relatively equivalent sorts of testing collection methods, especially when referring to PCR testing, which is very sensitive if the virus is actually there. A number of studies now have suggested there's intermittent viral shedding. No one knows quite why this happens, but because it does happen, it puts some holes in what our gold standard is, which is PCR. So how do hospitals accurately test for COVID-19 in a perioperative screening? That was our big question. So if you take a look at this slide, especially where the stars are, we were intrigued by this seminal paper that Dr. Tao and colleagues published. This married the idea of combining PCR testing with antibody testing to yield information of up to 99% sensitivity for disease that started between 8 and 14 days after symptom onset. We still have some limitations for the very early infected, but this strategy would give us more confidence than relying on PCR results alone. Taking a look at just a single PCR result and the ability to detect disease, we see that there is up to 30% chance of missing an infection, as we talked about previously. Our gold standard was just not as glittery as we would have liked. So, yay, I think we've got a plan here. According to a joint statement of surgical and anesthesiology groups, antibodies should not be used in preoperative screening. What did they say exactly? They said, currently, antibody testing does not have a role in perioperative screening and risk stratification. Uh-oh. They went on to say antibodies developed in the second week of symptoms, and not all patients who are infected with SARS-CoV-2 develop detectable antibodies. So let's break that down for a minute. Antibodies develop in the second week of symptoms. Well, that's helpful if you have symptoms, but not as helpful if you don't develop symptoms. And if you don't know where in the effective process someone is, you may be sampling someone who may not ever show symptoms, or the symptoms are so minor that you might only pick them up with something like a CT scan, for example. It is true that not all patients will develop antibodies after infection with COVID, but that does not negate the usefulness of a positive antibody test in those that do. And they went on to say, additionally, antibody tests have the potential of false reaction, as infections with other coronaviruses may result in false positive reactions. So I would say potentially that was true in the beginning when we had largely unregulated testing. Now we have very good antibody tests from major manufacturers. So I think that you can rely on this test if the testing is done in a reputable laboratory. Virtually all of the hospitals in the US now and our major reference laboratories are going to have tests that have high sensitivity and high specificity. One thing that I would like to point out is something that the Council of State and Territorial Epidemiologists said, and specifically they said the detection of specific antibody in serum, plasma, or whole blood that indicates new or recent infection provides presumptive laboratory evidence of COVID-19 illness. So there are some caveats, of course. You cannot use serology or antibody testing as a standalone diagnosis. However, if you use it in conjunction with symptoms and other data that you have, it is a very good way of diagnosing an otherwise vexing diagnosis in which PCR is not readily positive. So there's twin challenges. Antibody testing is not recommended for preoperative screening, but yet the PCR testing can generate a false negative. So going back to our two tests, we as healthcare providers are faced with big challenges when it comes to that perioperative screening. Well, at Methodist Health System, we did implement dual testing for our perioperative patients. And in fact, we did this in conjunction with our surgical and anesthesiology physicians, as well as in conjunction with the laboratory physicians and administration. To be fair, we had implemented this strategy prior to the dual statement released by the anesthesiology and surgical groups. And because we thought that our strategy was well thought out and supported by currently available evidence, we continued because we had such good evidence that this dual strategy was going to provide better confidence for our patients. I want to say a few words about our experience early on with antibody testing. I'm very happy to say that we had VITROS analyzers in all of the 4 acute facilities that make up Methodist Health System, and that we had a lot of history with Ortho Clinical Diagnostics. We knew them to be a good, reputable company. We thought that products that they brought to market would have good statistics to back them up. And we also knew them to be a company that if this turned out not to be the case, they would work on that, alert people when needed, and not lead us astray. So we were ecstatic to see the sensitivity, specificity, and positive and negative predictive values of this test. So the estimate of performance for the sensitivity and specificity is 100%. Being a skeptic, we'll call that approaching 100%. And looking at those confidence intervals over here to the right, they're also pretty good, up in the 90s and the high 90s. The positive predictive value at a prevalence of 5%, since those numbers are dependent upon knowing the prevalence, which we don't know at any given point in time for this pandemic, we're estimating basically also at 100%. But you can see in the confidence interval that it may dip down into the 80s, but a very good test which can be relied upon. And if you utilize these in a higher prevalence population, or a population that you would suspect to be higher prevalent out of your total population, especially for persons under investigation, this is a perfect place to start with this utilization. So we, like many of you, started out using a dual testing strategy with only our perioperative patients. Many of you probably have something that looks like this in terms of what your initial historical screening is, taking a good history on these patients, making sure that they're asymptomatic, they don't have concerning exposures, and they don't have any evidence of COVID. So we expanded our dual testing at that point to also include symptomatic patients that were going to the ORs, i.e. those patients that were already hospitalized. So while this particular strategy outlines how we got to the testing for our outpatient preoperative group, we were also utilizing this on our patients who were in-house who may have had symptoms that could be attributed to COVID. Finally, we get to the part where we're actually doing the testing in our pre-procedural COVID-19 test algorithm. So we're doing dual testing. If patients were negative for both, they're onto the OR and everyone is happy. If they are positive for either, the surgical acuity was evaluated and they were treated in the OR as if they were COVID positive. So we have massaged our algorithm a little bit to now, we initially started by delaying these patients for 14 days and then retesting them again at the end of 14 days. Of course, antibodies at the end of 14 days that were positive on the initial test didn't further delay. However, a positive PCR would delay. We have moved on now to a 10 or 20 days through the CDC's recommendations. This algorithm really is a fairly conservative measure because we knew that we would have some patients that were not actively infected, but we were going to delay their surgery as if they were such that we could protect them in the best way possible. And we only really wanted to delay surgeries in those patients who could afford to have their surgeries delayed, in which it wasn't going to cause more harm to delay them than it was to perform the surgery emergently. So our approach aligned to updated CDC guidance. So we can utilize antibodies to help diagnose acutely infected patients. We can't utilize antibodies as a standalone method to do that. And because antibodies may mean that you previously had disease, but now you don't currently have it, but it does suggest that at some point you've been exposed to illness. So we had some dual testing challenges when we started that I've alluded to. One was how to handle patients who are persistently PCR positive, which now we've moved away from with our new 10 and 20-day no test out strategy. And of course, there's this need for ongoing revision due to new information, new guidance, and data. We have had an increasing number of infections that has led to increased antibody percent positivity. So our outcomes are important because how are we going to recognize success? There are a number of ways to do that, and the best way to recognize success is with data. We don't have all of that data yet because we need to compare our morbidity and mortality results after we gain enough patients in each one of these pools to compare to other hospitals. I can tell you that our surgeons, anesthesiologists, and administrators felt very good about what we were doing. We have not seen increased morbidity and mortality that we have been able to identify, and we have not seen increased outbreaks in our healthcare workers, specifically in our OR, taking care of these patients. As with COVID, in almost any area you're looking at, it's a moving target. New challenges are afoot with higher infection rates, increase in the presence of antibodies in the population, and vaccines on the horizon. That's definitely going to change what your antibody strategy might be. It requires a need to layer on other diagnostic data and patient history when you're talking about serology. It's important to know, has this patient been previously diagnosed with COVID? Have they been tested before for antibodies? Was that the result of that test negative or positive? And protocols are evolving to accurately test patients for perioperative screening and testing almost on a daily basis. For us, as the antibody prevalence goes up, it will be more difficult to maintain this dual testing strategy. So certainly there are potential future applications of antibody tests. They can be a surrogate for neutralizing antibody tests, which most labs are not going to be able to perform. They're not going to be commercially available probably ever. To assess vaccine efficacy and monitor antibody levels over time. And you might even go a step before that. Could serology tests be utilized to determine who would get limited vaccines as they become available? If patients already have antibodies, especially to a certain level, perhaps they wouldn't be the first in line to get a precious resource with vaccination if they're already essentially protected with antibodies that they have developed from exposure to SARS-CoV-2. And then there's qualification of convalescent plasma from donors who have had COVID-19. So these are all very important things that serology testing are providing to us right now. There are a couple of tests that have been approved by the FDA to do semi-quantitative testing to help assess the level of an individual's immune response over time. We're looking for something that can reliably be compared to neutralizing antibodies. And we certainly have ortho as a great test that qualifies our convalescent plasma donors. Can we figure out if a certain level of antibody means that you do have long-term humoral? Can we figure out if a certain level of antibodies mean that you do have long-term humoral immunity? I think we will be able to figure that out. So I think that the story of serology is really at the beginning of COVID-19, and it's not going to be particularly surprising to me if this is a universal test to assess not only have you been exposed to the virus, but have you made an appropriate response to a vaccine? Have you been exposed to a virus and now your antibody titers have waned over time? And it may be something that becomes regularly tested to let your clinicians know where you are in the course of this pandemic and if you're protected or not. I certainly appreciate everyone's attention to my talk today, and this is a story obviously still unfolding, and keep following the science. The science is not changing, but our understanding of what the science tells us is. So thank you all very much.
Thank you so much, Dr. Roush, and we hope you enjoyed this session and that you understand the importance of dual testing and how to implement dual testing in your perioperative screening workflow. Make sure to view our other AACC session, The Other Pandemic, what you need to know about the new HCV screening recommendations. Thanks again for joining another session of the Ortho Infectious Disease Educational Series. I'm Mike Carboni. Have a good day.